Hi, I'm Jessica Jordan.
And I'm Anya,
and we are Pediatric Critical Care RNs at Nursing Evolutions.
So today we're going to talk about a case study about an 11-month-old patient who was recently admitted to Nursing Evolutions and how we as her nursing team would progress her care and what we would talk about with providers at her appointments today.
So her first appointment is GI and dietetics, where we're going to talk about advancing her feeds.
So she recently had a swallow study done, and the doctors have recommended, based on the results, that we start introducing pureed foods with tastes of 1 to 1.5 milliliters. So we're going to start doing that with her, and we're going to watch really carefully for any signs of aspiration or reflux or intolerance, and also possibly have to work through some oral version that she may have developed.
We would also work with the team talking about changing what we're doing with her G and J tube. The first thing that we would talk about is decreasing the amount of time that the vent is attached to the G tube, and hopefully if she does well with that, then we can start increasing the rate that's going through her J tube so we can start introducing breaks.
And then once she's able to have faster J tube feedings with breaks, we would start introducing G tube. So we would start doing that with medications because that's a smaller amount, which is easier to tolerate. Once she's tolerating medications well, we would introduce slow G tube feedings and slowly progress, much as we did with the J tube, until she's able to get fast bolus G tube feeds with breaks.
And the only thing we're really watching for with that is signs of acid reflux or intolerance in the changing in the feeding plans.
So her next appointment would be PT-OT, where we would talk about progressing her mobility. A lot of our patients in this situation, when they come home, have very flaccid muscles and flat back of the heads from laying supine in a hospital bed for their whole life. So some of the stimulation and activities that we would do with them would include things like facilitated rolling, dynamic sitting, tummy time, which we often do for trach vent kids. We do that tummy to tummy because we do have a trach hanging from the neck, so the nurse is able to really facilitate that and keep control over the trach to prevent any unintentional decannulation. And we would also work on sitting independently and developing trunk and arm and leg muscles.
If we did have an older patient, we would start talking about maybe adaptive equipment like a stander or a gait trainer, but what Anya said is what would be most appropriate for this patient.
So our next appointment that we would go to would be pulmonary and otolaryngology, who are in charge of the trach and respiratory systems and is a big part of what we do.
So since our patient is doing so well at 97% or above oxygen saturation on 2 liters of oxygen, the first thing that we would talk to the team about is weaning her off of her oxygen. And so we would get an order to start slowly reducing the amount of oxygen running through the ventilator and looking for any signs that she is not tolerating that, and that would look like desaturation, increased respiratory rate, increased heart rate, or changes in her work of breathing. And for her age group, we'd mostly be looking for increased work of breathing from distal to proximal, or any kinds of signs of anxiety that she might have. But we know that we can always just bump that oxygen back up to 2 liters if she was showing any of those signs. And then if we got her successfully down to room air, then we would talk to the team about getting a bronchoscopy because we know that she does have a partial upper airway, knowing that she can have nasal flaring while she's crying.
So once we get the bronchoscopy results, if they're positive, we'd be able to talk to the providers about decreasing the ventilator settings, which would allow the patient to be responsible for more of her own breathing, initiating her own breaths and drawing air in through her airway herself, relying less on the ventilator to do the work for her. And once we've got that established, we'd be able to introduce ventilator breaks, which is really exciting. And so while on a vent break, the patient would wear a heat moisture exchange, or HME, which goes on their trach, provides some humidity, and also prevents foreign objects from becoming lodged in the airway. We usually would start with pretty short breaks, 5 to 15 minutes, up to several times a day, to make sure they're tolerating it well. Once they're able to tolerate breaks while awake, we would start introducing nap time breaks. And once they're able to be off the ventilator for their whole nap, we would start introducing nighttime breaks. And once they're doing that pretty regularly, we would be able to ask for another bronchoscopy to reassess the airway again.
And if they have an established upper airway that we know is usable, then we can start talking about CAP training. And they would start with a PMV, which is a semi-permeable membrane, allowing some air to go out the trach, but more air to be forced through their own upper airway, actually stretching the airway. And that is used kind of like with ventilator breaks. We do it in short bursts and increase over time. And then eventually we hope to get to a full cap, which actually allows no air to go out of the trach and all of the air to go through the upper airway. And we use this more and more time throughout the day, not at sleeping times, until we get a sleep study done where they can wear it And if they wear it all night successfully through the sleep study, then we have some pretty exciting prospects.
So once they're able to sleep all night capped, then we can talk about decannulation, which is kind of the end goal with the trach patient. So that would mean that we'd be able to actually remove the trach and have them be able to breathe through their own airway. So that's really exciting, and once we get to that point, the patient can receive up to 30 days more of home nursing care, during which we would monitor the stoma to make sure it's closing and healing properly, that there aren't any complications from the procedure, and also help prepare parents to take over full independent care without nurses anymore. And then at that point we would discharge the patient, and it's an amazing experience to take these children from having some really hard starts in life and bring them to the point where they're running and playing and
making friends and going to school, and we get to visit them more as friends than as nurses.
Yeah, it's great. We get to come and visit with the families and keep in touch because we've become big parts of their lives and they become a big part of ours, and it's just a really rewarding experience, and we love what we do here at Nursing Evolutions.
Yeah.